So let's discuss about the Goldman perimetry. As I have already discussed in my previous video, that Goldman perimetry is specially done. It's a kinetic perimetry. Yes, we can do study, but definitely kinetic perimetry and procedures and the interpretation. Yes, I'll go few not deeply, but basically you have to go deeply because in clinical setups and hospital setups, you have to interpret anything perimetry with the disease and the clinical findings. It's not about just watching perimetry and just giving everything. It's not about that. You have to correlate with the clinical findings and clinical signs and symptoms, definitely. Okay. Perimetry, just to remind, is a subjective examination, not objective. Estimate to do what to do. Estimate the extent of visual field. And I have already told you three things: visual functions throughout the visual field. It enables detection and quantifying the damage at the visual field, monitoring change over the time, as I have discussed earlier. So basically, principle is always light difference sensitivity. In the visual field, what is light difference sensitivity? That sensitivity reflects the capacity of eye to perceive brightness differential, that is brightness difference, between what? Between target and its background. That's what light difference sensitivity. So basically, it's defined as L1 divided by L2 minus L1, where L1 is background, L2 is a luminance of the target. That's why L1 background. What is the difference between luminance and the target? That's okay, fine. So how differential diagnosis could be measured? In case of kinetic and static, kinetic we come from non-seeing to seeing. In static we come at the same place, do not change the place and the size, but definitely as brightness. We differ in the brightness, but in case of there, we don't differ in the brightness and the size. We change. We come from non-seeing to seeing. That's why it's kinetic. Movement is static. There is no movement. Okay. So let's come to the Goldman perimetry. So what is Goldman perimetry? Basically, it's most widely used instrument in manual perimetry, but there are very few places, especially in Nepal and India, where manual perimetry, like Goldman perimetry, is done. But still, in Nepal, my institute, we always used to do Goldman perimetry. Okay, what it has calibrated ball projection. There is a ball, it's definitely, and with the background of the intensity is about 31.5 apostable. Okay, it's always came into your exam, especially in MCQs. So project the target of the ball set in the 3 centimeter from the cornea of the patient. Basically, patient put his chin here, head rest here, and from here the ball distance is approximately 33 centimeter. And the target is dot, and the dot has definitely varying size and illumination. So we'll definitely going to talk about this. So target size, it represented by the Roman numerals from 0 to 5, and each step there is 4 times larger of what? Definitely area. Okay, see, 0 means the area of 0.0625 mm square. 1 means multiplied by 4, 0.25 mm square. 2 means multiplied by 4, 1 mm square. 3 means multiplied by 4, which is 4 mm square. 4 means multiplied by 4, which is 16 mm square. 5 means multiplied by 4, which is 64 mm square. And corresponding diameters, and diameters in degrees. Okay, sometimes it's so tricky. In MCQ, they do not ask about the mm square areas, they ask about the diameters sometimes. So you have to remember it if they want to set up a quite tough MCQs. Okay, so target illumination, just remember these things. Target illuminations, you have these things. See, 1, 2, 3, 4, A, B, C, D, E. What that means? The luminance settings expose the units it called apostibles, as I have already discussed. This is candela per meter square. The two sets of filters are there. One is 1, 2, 3, 4. Another is A, B, C, D, E. Okay. Actually, in that 5 steps, which is 10 steps. 1, 2, 3, 4 settings represent 0.5 log unit change. That means 5 decibels change in the brightness. At the same time, ABCDE means steps representing 0.1 log unit change. That is 1 decibels change in the brightness. I don't know they ask this in MCQ or not, but in my book I have written this as an MCQ. So just remember that there have chance 8 MCQ camps, for example, 1, 2, 3, 4 represent in the Goldmann perimetry, how much decibels change when you change in one step. So, for example, it's definitely 5 decibels the answer. Okay. So, target brightness. So, illuminance change are controlled in log unit steps in apostable. Typically, brightness of 4E, for example, 4 is highest, isn't 1, 2, 3, 4, and ABCD E is highest. That's why it's around 1000 apostable, and 3 means 315 apostable. 2E means 100 apostable. So it's very important when you reduce one ABCD. So note that the log of the radius ratio is the luminance, basically 10 log 1000 divided by 350, which is 0.5 log, as I have told you, the 5 decibels, isn't it? So 10 log 315 divided by 10, what is 0.5 log? It means the reducing by 0.5 log. So it's very important concept. Just understand this concept, okay? Target range in the Goldman. So more than 1000 combination of the size and intensity of target are possible, isn't it? See, let's just make it simple assumption. 6 sizes, 5 targets illumination. I think 5 or 4. I think it's 4, isn't it? No, 5. It's a 1 to 5 and 1 to A, B, C, D, E. 5 steps. So means 5 into 5. What is it? 5 into 5? It's 25. 25 into 10? 160. 100, what is it called? 150. And then again, combination of each two others. So that's why it's more than 100 combinations are possible. It's simple mathematics, isn't it? So probability. So more than 100 is possible, and but only few isotopes are needed to define the visual field. It's always important. Very few we do, very few isotopes. The size 0 generally omitted. It's I don't think I have never ever done with the 0, because the result of the plot is inconsistent. It's so small that it's inconsistent. So the finally intensity of the filter is usually set on the letter E because of the high intensity we use, and we know from E, that's the from ABCD, that means the 1 decibel change, isn't it? Which estimates the small incremental filters, because ABCD always change by small 1 decibel, but from 1 to 3 4 it's 5 decibel, it's 0.5 log unit, isn't it? So we usually do target size is size first, this V, illuminance first stands 4 letter, and finally small fine ABCD. It's always there. Okay. So standard visual field plot for right eye. For right eye, definitely you will see a visual field defect in right side, and there are usually 3 isopters we plot. So some interesting facts about this is a change in one number of intensity. So it's roughly equivalent to change in one Roman numerals of the size. Basically means, see, if we increase size by 3 to 4, we have to decrease from 4 to 3. So basically, roughly, it's not equivalent, but roughly you understand this. Okay, isopter plotted with the target of equal sum of Roman, which means Roman numeral size plus number intensity, that consider equivalent. Basically means, see, 3 and 4 7, and 3 or 4 7, isn't it? Yes, that's kind of thing. For example, this, see, 4 plus 1 5, 2 plus 3 is 5. So we sometimes see like this. So required equipment for visual field mapping. What are the required equipment? Definitely Goldman lens holder. We need it because we have to correct refractory error. Recording paper, color marking, because different isopters we mark differently. For one for red, one blue, one black, and whatever recommended are there. I'll talk about it later. Patch for the monocular testing, because we have to patch another eye because it's monocular testing, isn't it? So basically, this is just a Goldman setting. Patients sit here, put chin here, head rest here, one eye is passed, horizontal cut in the machine, because here we throw the light, pendoscope handle, handle we use that handle, isn't it? And patients see that buzzer, took that buzzer, and patient just buzz it when they can see the field. So front beak, this is the fixation target, because from which we can look the patient's eye. And this lens holder, yes, I have already told about this. Chin rest, there is chin rest. Head rest, there is the head rest. Okay, this is the patient's side. And the patient's preparation is most important. When plotting the peripheral field of view, no RX is one because RX is used only for the central vision, isn't it? RX is not one for the peripheral vision, except for the patient with high myopia or hyperopia, for example, plus minus 8, because high myopia, hyperopia cannot focus. So, aphakia, contact lens may be needed to one because plus contact lens spectacle will reduce the field of view, isn't it? So patient preparation when plotting for the central 30 degrees and Rx is needed. Definitely central 30 degrees because central means 30 degrees. Depending on the patient age and the distance Rx value, we definitely consider presbyopia too, isn't it? So for example, 0.25 cylinder, no need to wear. Rx about one cylinder is spherical equivalent we can do. Rx more than one, the use of the cylinder in the lens holder is in the correct axis is recommended. So these are the things that you have to understand when cylinders should be corrected or not. For hyperopia and emmetropia, we use the distance Rx for the patients, isn't it? It's very simple, but definitely you have to think about adding power because you are going to test in 30 centimeter. So it's very important to use certain guideline power to the patients, okay, because you are testing in the near. For myopia, what is the recommendations? With the distance Rx between this to this, use the distance Rx add for the x ages because you have to know the distance Rx for the add, we have to add it. If the resultant plus lens is use it, basically if there is any resultant add, if he's myopic and then you have to add for his age, then you have to add or do the all overall calculations. If the resultant Rx is minus, do not use because of minus can focus for 30 centimeter. If myopia is more than this, then we have to think about the Rx, distance Rx, okay? So for all patients, use full aperture trial lens. Never use half aperture trial lens. Full aperture trial lens, very because half aperture trial lens, trial lens rim will create visual field defect, isn't it? That's why we need full aperture trial frame. And place the lens holder and lens close to the eye possible. If we place to the close to the eye possible, then visual field expands, isn't it? The place spherical lens closest to the patient and the cylinder lens away from the patient. That's the same thing when we do subjective refraction. Place cylinder lens farthest from the patient at the appropriate axis. That's important. So basically guideline, chin in the chin rest, forehead in the against the forehead against the bar. Direction to the patient, fix it at the center and do not directly in front of you. Fixation must be in the center. That's why you examine. Place the buzzer when white dots and target appear. You have to instruct the patient this line. Okay. Remember to monitor fixation all the time using telescope. This telescopic system is towards our side, towards our examiner side, and we have to do the monitoring all the time. That's very important. Okay. So guideline to plot. First demonstrate the procedure to the patient, then don't just jump into the examination. First demonstrate them, okay? General rule for plotting isopters are mapped for the particular stimulus size and the intensity. Then as I have already told you, from non-seeing to seeing while presentation stimulus, it's very important. Read this line, okay? The move at the rate of 5 degrees per second. Don't go so fast and don't go be so slow, okay? That's very important. This is the same principle used for RAF rule, isn't it? Do you remember from orthotics examination? RAF rule must be at certain speed, not too much high, not too much slow. Present the kinetic at, we usually do 15-degree intervals. Turn stimulus off after each patient's response to move target into periphery, because do not you come from periphery to center and patient buzzed. Okay, I can see the target. Then you turn off and you move away. Then again plot 15-degree away from that, isn't it? That's the basic process. So moving target stimulus to opposite hemisphere, it's always important to see. So pantograph handle can be moved freely up and down, right and left, while the right and left hand in visual field. So basically, guide pantograph arm curved around the sign showing the bottom field of your record chart. Do not force to move the pantograph and should swing freely, because if you move forcefully you will break it. So it's always important. So ignore initial 2 to 3 response after changing the stimulus. It's very important. When you will change the stimulus, first response should be ignored, and then later on, if patient habitual, then move on. Okay. Hold the marking tip of paper before respond to stimulus. It's always important. So hold marking tip of paper before responding to stimulus. So guideline for plotting: begin in the far periphery and kinetic plot isopters in the all meridian. Always begin from far periphery, non-seeing area, not just seeing area. Okay. We normally use B4E, I3E, I2E target depending on the age. Definitely depending on the age. Plot blind spot. It's very important. Plot blind spot. Only 4 meridian is required. More if regular or large. If there is regularity or large, for example, in case of papilledema, then there may be need of more than 4 meridians to plot blind spot. But definitely 4 meridians are okay to go. Use I4E for blind spots. Always good. So within the isopters, there is use the stimulus that does encompasses the blind spot. If 1,2E, 1,3 isopter doesn't encompasses the blind spot, then you can use the stimulus that encompasses. You can sometimes broaden the stimulus, or sometimes you can use a little bit larger or brighter stimulus. That's okay. So guideline: central static test I2E is better. Explore any scotomas. The kinetic is plot with I3 stimulus only if suspected defect area. If you suspect defect area, you can slightly enlarge the brightness and then you find out this scotoma, isn't it? So static test can be done by I3 in I2E isopters within the I3 stimulus scotoma search. So basically, you can do static test, but we usually do not do static test. We can do a static test to find out how deep scotoma is. Okay. So special case plot for glaucoma: explore 20 degrees and then nasal meridian to suspect what? Nasal defect, isn't it? Yeah. The target motion is repeated to verify the consistency of the discrepancy. It's very important. You find there is a defect and you stop there. No, you have to go there again and again to find at least yes, you are confirmed that there is a defect. Okay? Kinetic target moving perpendicular to the suspect nasal steps are made from the defective area towards the meridian. Basically means it's for glaucoma, it's field defect. So static presentations of the same target are made either on the side of the meridian or to confirm the target is seen on side or but not to others. Basically means if there is some defect, for example, X and O are the static representations of the same target, moving with O marking location where the target was seen and X was not seen. Basically here you cannot see, and if you move from here to here, then patient buzz, then you confirm that this area is defective, isn't it? Sometimes you want to increase a little bit intensity too. So point away from the meridian to test, and with more details, exploration of the supernasal or defective areas shown an arcing nature of the loss. Basically, sometimes you move like arc, isn't it? Some if you find defect, then you want to move a little bit superior, a little bit inferior, so that you can extend, you can come to know the extent of the visual field defect, isn't it? Finally, kinetic isopters are drawn. Basically means here's the defect. So this is the kinetic isopters. So if isopters are not perfectly round, then we always suspect these areas with the defect, isn't it? So mapping out in neuropathic cases is very crucial. Most frequent defect noted in arcuate defect, neuropathic and central scotoma. So main region of concentration is 20 degrees in nasal field. So this area should be explored with use of both kinetic and static techniques. Static is very important in case of central visual field defect. Suprathreshold presentation or several prequadrant is done. If any abnormality is seen, no response to test target, suspect the presence of scotoma. It's always better to suspect if there is no response. Okay. In such a case, same target is moved in the map or plot border the scotoma. The plot the boundary of the scotoma in a minimum of 8 meridian. It's always important in case of neurological case. Minimum of 8 meridian, you plot the boundary. Okay, to estimate and plot the severity and depth of scotoma, what you do? If you want to know the depth of scotoma, you increase the illumination, isn't it? So place the static target its central and increase the stimulus by 0.5 in log unit. What do you mean by 0.5 mean? You move from 3 to 5 or 3 to 4, maybe 4 to 5, from 1 to 2 or 2 to 3, isn't it? So until the subject responds to it and replot the boundary. If any scotoma is noted, kinetic plot is boundary and determine its depth. Okay, so always depth, static is better. So mapping the vertical meridian. What is the vertical meridian? So first, suspicion neurological lesion. Whenever there is vertical lesion means, for example, or the pie in the sky or pie in the floor or whatever. Kinetic perimetry is done with the three vertically moving target chosen in the to reveal the isopters at 30 degree, 40 degree or 50 degree eccentricity and indicate the arrow which is flank and vertical meridian. Basically means this meridian. See, you will do the visual field in this meridian, vertical meridian. Okay, then static technique is applied if ta- take the same target used to mark the kinetic isopters and then flash it again with the isopters and making comparing response to either side of the vertical meridian. So if you find any vertical meridian defect, then static perimetry is also a best way to examine the depth and to examine the vertical meridian defect. Okay, picking retinal disease. How will map retinal? The retinal disease like central serous retinopathy or macular degeneration, cone dystrophies mandate careful testing of the central 20 degrees because they are the disease in the central retina. Best to be done with automated perimetry. Yes, definitely best to be done with automated perimetry. For RPs, careful examination mid periphery because RPs start from mid periphery, retinitis pigmentosa, isn't it? So retinal artery occlusion produce defect similar to the optic neuropathy and requires similar approach. Yes, definitely we have to have a clinical diagnosis and clinical signs and symptoms, and there are a lot of things that we have to differentiate. Not it's not just about the visual field. Okay, so recording is very important. How you record? Very important patient's demography and RX used, pupil size, eye tested, whether it's right or left, patient cooperation and fixation. Sometimes patient gets very good result, but it's not about that. Patient cooperation and fixation is very important. You have to see the fixation loss. Okay, indicate the target size and use in the bottom of the right because so you have to know the target size, isn't it? So color coding is I2E blue, I3 orange, I4 is red, 2,4 green, 3,4 purple, 4,4 brown, 5,4 black. It's very important. You'll see color coding in isopters. So expected finding for the normal isopters. Normal isopters, what do you expect from normal isopters? Patient under 50 years is periphery by this, isn't it? Intermediate by this, central by this. Okay. So patient 50 years old, then periphery by second 4E, intermediate by 1 4E, central by 1 2E, 1 3. It's very important. So interpretation, the visual field is considered abnormal if the threshold value are significantly brighter, that is 0.5 log unit or more than expected value, and or scotoma or depression are present. So that is very important that if you significantly bright the stimulus by 0.5, that means 1 to 2, 2 to 3, 3 to 4, then there is scotoma you found. That scotoma is most likely there is scotoma in depressions. Okay, the most likely defect. It's very important interpretation. But there are a lot of things that we have to do in interpretation of visual field. Especially we have to know which type of disease create which type of visual field. That's very important. Okay, and I think you have to read by yourself which type of disease create which type of visual field defect. But we will definitely go through it in, roughly. Okay, so till these are the references, but yes, definitely this is very 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 good book. So Bistan, cheers.